Hello friends, good afternoon. Today we'll be discussing on a very important topic, that is cesarean section. It is solely for study purpose, and we'll begin with, we'll go with recent advances. Just give me a minute to check if I am audible and visible. Okay, so this is the contents of my presentation. The cesarean section derives its name from the notification lex caesarea, and the other explanation is there, which means to cut. The incidence of cesarean section is steadily rising, and it is a third common surgical operation in worldwide, according to WHO in 2006, and also according to WHO, the cesarean section rate in Nepal is approximately 17% in 2015, which is increased from 7% in 1990 to 21% currently, and it will increase up to 29%, that is 1 in 3 of all childbirth by 2030. The WHO recommends a student such an ideal rate of 10 to 15%, but 1 in 5 women, that is 20% of women, are giving birth through cesarean section. The cesarean delivery can be defined as the birth of the fetus through laparotomy, then hysterectomy. It is not applied to removal of the fetus from the abdominal cavity in case of uterine rupture or with abdominal pregnancy. Some other terms are perimetum, cesarean delivery, and peripartum hysterectomy. Perimetum cesarean delivery is when the hysterectomy is done in a woman whom death is expected soon or who has just died in order to save the mother, in order to save the fetus of a dying mother. And in peripartum hysterectomy, it consists of cesarean hysterectomy that is done during cesarean delivery after the birth of baby, especially in placenta accreta spectrum. And the other is postpartum hysterectomy that is done shortly after the delivery, usually vaginal delivery, especially in case of CBA PPH. According to urgency, archaeology has classified cesarean section into four classes or four categories. Category 1 is emergency cesarean section, which is done in case of immediate life threatening to either mother or baby or fetus, like in case of cord prolapse, in case of fetal distress, in case of severe fetal abruption, and antepartum hypovolemia, in uterine rupture or scarring, or in failed institution delivery with fetal distress. Category 2 is urgent cesarean section. Maternal and fetal compromise is present, but it is not immediately life threatening, like in case of APS without maternal hypovolemia, in case of failed induction of labor, in normal Doppler study, and non reassuring cardiotograph. And in category 3, it is scheduled cesarean section, which will need early delivery, but it is not due to maternal or fetal compromise, like in case of previous lower segment cesarean section in labor, in cephalopelvic disproportion, in breech in labor, and in category 4, it is elective cesarean section that is done at the time which is suitable for woman and maternity team, like in case of malpresentation, multiple pregnancy with first twin non-cephalic, and CDMR, that is cesarean delivery on maternal request. According to normal primary cesarean section and repeated cesarean section, if it is done first time, then it is known as primary cesarean section, and if it is done with this previous cesarean section, either one or two or multiple, then it is known as repeated cesarean section. And according to uterine incision, lower segment cesarean section and upper segment or classical cesarean section. In lower segment are usually a transverse incision is given, and rarely vertical incision can be also given. And in case of upper segment cesarean section or classical cesarean section, The incision is usually in upper segment and is usually vertical. Now moving on with the relevant anatomy of anterior abdominal wall. The function of anterior abdominal wall is to confine the viscera and accommodates the expanding uterus and provides surgical access to internal reproductive organs. The superior border is made by the lower edge of rib cage, that is from rib 7 to 12. Inferior margin is formed by iliac crest, inguinal ligaments, and pubic bones, and posterolaterally it means at the lumbar vertebra or lumbar spine and the adjacent muscles. The layers of anterior abdominal wall are skin, subcutaneous tissue or superficial fascia, then muscles, then fascia transversalis and extraperitoneal fat and parietal peritoneum. Detailing skin, subcutaneous tissue, aponeurotic layer, rectus abdominis muscle, external and internal oblique muscles, transverse abdominis muscle, transversalis fascia or fascia transversalis, and periperitoneal adipose radial tissue and peritoneum. So skin, there are Langer lines, which was described by the Langer, which run across transversely, and they are oriented with the dermal fibers of the skin. And in anterior abdominal wall, they are lying transversely. So the transverse incision give a better cosmetic results like international incision, whereas a vertical incision will sustain a greater lateral tension and thus develop wide scars. In case of subcutaneous tissue is divided into two layers, that is superficial fatty layer, which is camper fascia, and deep membranous layer, which is scarpa fascia. Camper fascia continues into the perineum and it provides a fatty substance to the mons pubis and labia majora, and then it blends with the fat of ischianal fascia. It is a fatty fascia, and deeper membranous layer is scarpa fascia, which continues inferiorly to Colles fascia. The epineuritic layer is made up of rectus sheath, which has two layers, anterior layer and posterior layer, and it is a broad sheet-like eponeurosis, which is formed by the sheath of the other muscles, and it encloses the rectus abdominis and pyramidal muscle if present, and it fuses in the midline to form linea alba, and laterally at the linea semilunaris, and above the arcuate line, the anterior layer is formed by this is the external oblique abdominis, internal oblique abdominis, and transverse abdominis. So the anterior layer of rectus sheath is formed by external oblique abdominis and anterior layer of internal oblique abdominis, whereas the posterior layer is formed by posterior layer of rectus abdominis and transverse abdominis. But below the arcuate line, the anterior layer of rectus sheath is formed by the fusion of aponeurosis of all three abdominis muscle, and posteriorly the sheath is weak, formed only by the transversalis fascia. Linea alba, as I said already, it stretches from Giffard process to pubic symphysis, and it is formed by fusion of aponeurosis of external oblique, internal oblique, and transverse abdominis muscle. Now moving with the muscle layer proper. Primarily, the anterior abdominal wall is made up of rectus muscles and associated fascia, and here the inferiorly pyramidalis muscle is present, whereas posterior lateral and lateral portion of the abdominis is formed by three paired broad flat muscles, that is external oblique abdominis, internal oblique abdominis, and transverse abdominis. External oblique abdominis coming in the pocket fashion from the lower eight ribs and inserts in pubic symphysis, whereas the internal oblique abdominis arises in the anti-pocket direction from the iliac crest and inserts behind, and transverse abdominis lies transversely. The transversalis fascia, as seen before, it is a weak, as we have seen in this picture, this green line, this is a weak fascia that is in the inner layer and inner surface of the transverse abdominis, and it is separated from peritoneum by layer of periperitoneal fat, and it will form a continuous lining of abdominal and pelvic cavities inferiorly, which blend with periosteum and pelvic bones, and it continues with diaphragmatic iliacus and pelvic fascia. So it makes the internal covering of entire abdomen and pelvis. Now, peritoneum. Peritoneum is a single layer of epithelial cells which is supported by thin layer of connective tissue. Visceral peritoneum, densely wrapped. There are two layers. One is visceral peritoneum and parietal peritoneum. Visceral peritoneum will densely wrap the viscera, and parietal peritoneum will line the inner surface of abdominal wall, usually attached with the fascia transverse separated by periperitoneal fat. So, five vertical folds are formed by the underlying ligaments. As again, we can see in this picture, this is the median umbilical ligament, and there are lateral, and there are two medial umbilical ligaments and also lateral umbilical ligaments. So there are five folds of peritoneum. So single median umbilical ligament, pair medial umbilical ligament, and pair lateral umbilical ligaments. Now moving on with blood supply. There are two types of blood supply in the intra-abdominal wall: superficial blood supply and super deep blood supply. So superficial are usually superficial epigastric arteries, and deeper are superior epigastric arteries. As seen in the picture, this is the superior epigastric artery. This is the inferior epigastric artery that forms a margin that forms collaboration over here, and also the deep circumflex artery and musculocutaneous artery. So the deep vessels are the paired vessels according in this way. So superior epigastric artery and uh, musculophrenic arteries are from above, and these are the branches of internal thoracic artery, whereas the inferior epigastric artery and deep circumflex iliac artery are the branch of external iliac artery, common artery, external iliac artery. So the superficial epigastric artery is usually it arises from the femoral artery from origin and course diagonally toward umbilicus, and it is usually made with a low transverse skin incision. It is identified in halfway between the skin and anterior rectus sheath. It lies above the scapa fascia and it is several centimeters from the midline, and it should be identified and occluded surgically. So while cutting, when we go from skin to subcutaneous tissue, and we need to identify the superficial epigastric artery, occlude it, and then begin proceed. Now the superior epigastric artery. Superior epigastric artery is the continuation of internal thoracic or mammary artery, and it will enter into the rectus from the behind the seven costal cartilage, and it goes posterior to the rectus, and it has multiple branches which will supply the rectus muscle and also anastomosis with the inferior epigastric artery. Similarly, inferior epigastric artery coming from external iliac artery is the dominant vascular supply, which will ascend medially deep to inner ring and superficial to the transversalis fascia and crosses the lateral border of rectus and also enter the posterior rectus sheath and will communicate with the superior epigastric artery. So there will be a multiple collateral branches that need to be identified and before closing the abdomen. So sometimes a maillard incision is given, which will in which we divide or in which we cut the rectus muscle. In this case, inferior epigastric artery can be lacerated lateral to the rectus belly, and this will also, and sometimes these vessels also may rupture and cause rectus sheath hematoma. Venous drainage will typically follow the course of artery, and above the umbilicus it drains into subclavian vessels, and below the umbilicus it will drain into external iliac vessels. The lymphatic drainage is also important. Sometimes after giving infusion and healing, there might be subcutaneous edema or lymphedema because of cutting of lymphatic vessels. And above the level of umbilicus in the abdomen, the primary The lymphatics drain into anterior axillary lymph nodes and sometimes into internal mammary nodes. And at the level of umbilicus, they drain into liver through calcium ligament, whereas below the level of umbilicus, the drainage occurs into inguinal nodes and to iliac chain of nodes. And these lymphatics lie in between the dermis and fascia. Nerve innervation is majorly from the intercostal nerve from T7 to T11 and subcostal nerve, that is T12, and ilioinguinal and iliohypogastric nerves that arise from the lumbar one. So these nerves can especially the iliohypogastric and ilioinguinal nerves can be cut or severed, which in the lower transverse incision, or they can be entrapped with the extension beyond lateral border of the rectus abdominis, which will cause the loss of sensation, chronic pain in the mons pubis, labia majora, and medial upper thigh. And the intercostal nerves, these are the branches. Intercostal nerves anterior, are the posterior rami, and these are usually sensitive only. And this will extend ventrally between the transverse abdominis muscle and internal oblique muscles, and this will give rise to lateral and anterior cutaneous branch, which will also give nerve supply to especially cutaneous or sensory nerve supply to anterior abdominal wall and the tap, that is transverse abdominis plane block is used for post cesarean blockade, where the injection is given in the plane between the intercostal internal oblique abdominis and transverse abdominis, and this is numbed. Also, the dermatome is important. In T10 dermatome, that is at the level of umbilicus, anesthesia is required for labor and vaginal birth, whereas for cesarean section, at least up to T4 dermatome should be anesthetized. So as you can see, the ilioinguinal nerve, iliohypogastric nerve, T12, these two from lumbar, T12, and all the other nerves. And also, there are suture materials that are used in closure of the abdomen. There are two types. One is absorbable and other is non-absorbable. And in absorbable and non-absorbable, both there are monofilament and polyfilament. Non-absorbable when the maximum tension suture is more than 60 days, then it is non-absorbable, and mostly absorbable suture is used in cesarean section wound closure, except sometimes can be used for skin, the non-absorbable one. And the plain catgut or chronic catgut is used, or PDS, and the commonly used is monocril and bicril rapid, and the braided are Dexon, bicril, or panacril. And as you can see, the strength is more in case of braided. It is constantly same, and the tissue reaction is less and not security is average, whereas in case of relative strength and tissue reaction, the plain gut is strength is very less and tissue reaction is more. So usually for never use observable gut sutures for fascia, and also in case of infective causes we avoid using braided ones. Non-observables are rarely used. Now, preoperative consideration we need to consider for the history, physical examination, confirmation of date, and then timing of the scheduled delivery. According to uh, American Association of Obstetrics and Gynecology, there is no uh, exact timing for the scheduled cesarean delivery, but with elective delivery, it is better to avoid before 39 completed weeks, because there are some adverse neonatal sequelae Neonatal immaturity. Basic investigations are required like hematocrit, platelet, blood grouping, and serology. We need to arrange and cross-match blood and blood products. Informed consent is given. The patient should be admitted. Evaluation done by obstetrics and anesthetic team. So if food is stopped at least 6 to 8 hours before the procedure, and in case of uncomplicated patients, there might be moderate amount of clear liquid after 2 hours before surgery. But for emergency cesarean section, we do not wait for nil per oral. Hair removal by clipping is done or day before surgery. IV fluid administration is required at least 1 liter before anesthesia. Antacids can be given, and regional anesthesia is preferred for cesarean delivery. And antacid is given shortly before regional anesthesia or induction of general anesthesia, like proton pump inhibitor. And once the woman is supine, a wedge beneath the right hip and lower back creates a left lateral teeth to aid the venous return and avoid hypotension. Polycatheterization is done because of the procedure and spinal anesthesia. Preoperative vaginal cleaning with povidone. All the instrument, document, electronic drugs, and emergency drugs are checked. And skin preparation is done usually with chlorhexidine alcohol or povidone. Then draping is done. Antibiotic prophylaxis is important. A single IV dose of beta-lactam antibiotics, either cephalosporin or extended spectrum of penicillin, is recommended. 1 gram dose of cefazolin is efficacious and cost effective. An additional dose is required if blood loss is more than 1500 ml or duration is longer than 3 hours, or in case of obese woman more than 80 kg, 2 gram dose for cesarean section lasting 1.5 hours. And the extended spectrum, azithromycin 500 milligram IV can be added to standard prophylaxis prior to cesarean delivery for women in labor or with ruptured membrane to reduce the risk of infection or endometritis. And in a pregnant woman with history of infection with MRSA, that is methicillin resistant Staphylococcus aureus, a single dose of vancomycin is added to standard prophylaxis, and it is ideally administered 60 minutes prior to the start of planned cesarean delivery. And for emergent delivery, antibiotics are given as soon as feasible. The other preventions are glycemic control should be obtained in diabetic women with either GIK or insulin levels, and intraoperative normothermia should be maintained. Patient should not go into hypothermia. Then there should be a practice of timeout in which the confirmation of the site, patient, and procedure is done. Then the verification, introduction of genes, procedure length, anticipated complication, and special instrument request should be done. Instrument spawns and needle count should be done before and after surgery, and active communication during surgery is crucial. So this is the ERA's guideline for cesarean delivery, in which the similar things are there, uh, which we have just discussed. And during operative anesthesia, regional anesthesia is prepared. Here, warming is done, IV fluid warming and warming device. And for surgical techniques, blunt expansion is done. And for better outcome, euvolumia should be maintained always. Now let's discuss with why cesarean delivery rate are persistently increasing. According to Williams, these are the 9 causes that is increasing the cesarean section rate. Nowadays, women are having fewer children, and thus the greater percentage of birth among nulliparas who are more increased risks of cesarean delivery, and also because average maternal age is rising, and in older women, especially in older nulliparas, they have a higher cesarean delivery risk. And electronic fetal monitoring, that is CTG, is widely used these days, and it is associated with a higher cesarean delivery rate compared with intermittent fetal heart rate auscultation. Most breech fetuses are now delivered by cesarean. The frequency of the art of operative vaginal delivery and frequency is also declining. Obesity, which is which is increased cesarean delivery risk, has reached its epidemic proportions, and rate of cesarean delivery in women with preeclampsia have risen, whereas labor induction rate have declined. Similarly, the vaginal birth after cesarean delivery, that is VBAC, is decreased, and similarly, assisted reproductive technology is more widely used and linked with the greatest aspect of cesarean delivery because mm, after infertility, after IVF, the deliveries is usually the baby is usually precious, and patients as well as clinicians do not want to risk. Now, how can we reduce safely? We need to optimize the labor. We need to optimize the labor and also the management. The augmentation should be appropriately used. The fetal mentoring should be interpreted correctly. Senior obstetrician should always be involved in decision making. And if we suspect fetal compromise, then confirmatory tests should be done. What is the correct cesarean section rate? There is no appropriate cesarean section rate. It should be confined with maternal and perinatal morbidity and mortality rate, and it depends on maternal satisfaction and if medical legal cases and complaints are present and available resources and expertise for any health institution. If the rate is appropriate, we need to discuss or we need to evaluate in these parameters. So there is a system of 10 group classification for this identification or for the cesarean section deliveries rate, in which we will find out the number of cesarean section over total number of women, and we will see the relative size of group percentage, CS rate in each group, and contribution made by each group. This is done in every every perinatal morbidity and mortality discussion each monthly in our hospital also, in which we have this 10 group classification or Robson's classification, and we take all the different groups and we will identify the number of cesarean section, so how much it occupies the relative size, and how much the cesarean section is occurring and how much contribution it is making. And also a daily morning meeting of 30 minute is attended by all with events in labor ward in last 24 hours, an ongoing issue, that is labor ward audit cycle, that is also being done in our hospital, in which we'll discuss about any labor outcome and also the entire ward, including gynecology department. So this will help to in the handover process as well as any complications. Now, going on with indications of cesarean delivery, the maternal, fetal, and maternal fetal. Maternal, the prior cesarean delivery, abnormal placentation, maternal request, prior classical hysterectomy, unknown uterine scar type, or any prior uterine incision extension, dehiscence, prior full thickness myomectomy, genital tract obstructive mass, invasive cervical cancer, or trachelectomy or circulars, or pelvic reconstructive surgery or significant perineal trauma, pelvic deformity, HSV or HIV infection, which might pass during vertical transmission during birth, cardiac and pulmonary disease, cerebral aneurysm or AV malformation, pathology requiring other intra-abdominal surgery or perimortem cesarean delivery. For maternal and fetal, cephalopelvic disproportion, failed operative vaginal delivery, placenta previa or vasa previa, and placental abruption. For fetal, non-reassuring fetal status, malpresentation, macrosomia, congenital anomaly, abnormal umbilical cord Doppler study, thrombocytopenia, and prior neonatal birth trauma history. More than 85% of caesarean operations are performed for four reasons. One is prior caesarean delivery, other is labor dystocia or arrest, fetal jeopardy, or abnormal fetal presentation. And these three are the common indications for primary cesarean delivery. And for recurrent cesarean delivery, the first one. The cesarean delivery is higher maternal surgical gives provides a higher maternal and surgical risk for the current and subsequent pregnancies compared with spontaneous vaginal delivery. And in neonate also, the delivery offers a great rate of respiratory difficulties like transient tachypnea of newborn, surfactant deficiency, and pulmonary hypertension. The benefits are the low rates of perineal injury and short-term pelvic floor disorders. As we know, in case of vaginal blood, there is high risk of perineal trauma and leading to acute or chronic perineal problems. And for neonate, also there is low rate of birth trauma or intrapartum stillbirth. The steps are laparotomy, that is opening abdomen, hysterectomy, opening uterus, delivery of the fetus, delivery of the placenta, then uterine repair and abdominal closure. So skin incision, there are different type of skin incision for laparotomy. Transverse or vertical. The transverse is also again three types: phalansteal, malar, or zolcoin, and midline vertical. As you can see, phalansteal, zolcoin, and vertical midline. So phalansteal incision, it is an incision which is given in a low transverse, slightly curvilinear with concavity upwards, and it is 2 to 3 centimeter from the 3 centimeter above the superior border of pubic symphysis, and it is usually 12 to 15 centimeter. And the advantage is it heals better as it has better blood supply. The skin edges are opposed better since the incision is given along the natural line of Langer. So this is a cosmetic scar. Incision hernia is less, and it is not usually affected by increased abdominal pressure like during straining, coughing, or and also post-operative pain is less, and fundus can be palpated easily immediate postpartum. The other incision is malar incision, which is similar except cut is made on rectus abdominis muscle belly and sheath to allow wider access in the pelvic cavity. The other is zolcoin incision, in which it is transverse. This incision is transverse and straight, and mm, it is above the or cephalad to phalansteal. It is 10 centimeter length, and it is just 2 to 3 centimeter below the line joining the anterior superior iliac spine. Advantage is less fever, less pain and analgesic requirement, less blood loss, and shorter duration of surgery. Now, with the midline incision begins at 2 to 3 centimeter above the superior margin of symphysis, and it will be 12 to 15 centimeter in the length. A sharp or electrosurgical blade dissection through the subcutaneous tissue will expose the anterior rectus sheath. A small opening is made with a scalpel in the upper half of linea alba, Index and middle fingers are placed beneath the fascia to elevate it, and fascial incision is extended first superiorly and then inferiorly with the scissors. Then midline separation of the rectus muscle and pyramids muscle is done, and peritoneal entry is done. The advantage is for high infection rate to prevent a gap between the external and internal abdominal appendices. Emergent entry is faster. There is less injury to vessels and nerve, and also the decreased hematoma and neurological disruption in case of morbidly obese and if needed of access to other abdominal organs. So this is the table showing the difference between transverse incision and midline vertical incision. In transverse incision, it is superior cosmetically because it follows the Langerhans line. Midline vertical is inferior cosmetically. So, um, because it is lower incision, there is less rate of incisional hernia, postoperative respiratory interference, and also less rate of wound dehiscence. And but bleeding, hematoma, and neurological disruption is more, and it takes time and less spacious. Now the subcutaneous tissue. Subcutaneous tissue are usually opened from medial to lateral, and usually blunt dissection is preferred over the sharp dissection as there is shorter operative time, less chance of injury to vessels, and less perioperative pain. And superficial epigastric vessels are identified between the skin and fascia and then coagulated. Similarly, the fascia is dissected sharply in the midline. Inferior epigastric vessels lie outside the lateral border of rectus abdominis. Beneath the rectus sheath, they should be identified, coagulated, or ligated. And the lower edge is extended bluntly by pulling, by inserting the fingers and pulling, or sharply by grasping the inferior fascial edge first and separated fascial sheath from underlying rectus muscle until the superior border of symphysis pubis is reached. Superior edge is held with cocker clamp, and separation of fascia from rectus abdominis is completed in cephalad lateral direction. Now the rectus muscle layer is opened, and rectus abdominis and pyramidal muscles are present, which are separated in the midline, first superiorly inferiorly by sharp or blunt dissection to expose the transversally fascia and peritoneum, and the muscles are transected in Maillard technique. Now the peritoneum is entered. Peritoneum is raised. Peritoneum near the upper border of incision is opened carefully, either bluntly or by elevating with two hemostats placed approximately 2 centimeters apart, and this will lower the risk of cystotomy. The tented fold of peritoneum between the clamps should be examined and palpated to ensure that omentum, bowel, or bladder is not adjacent. Then the peritoneum is incised, and incision is extended superiorly to the upper pole of fascia and downward just above the peritoneal reflection of the bladder. Now we reach to the uterus, and in uterus we will start with the uterine incision, which is known as hysterectomy. So usually it is lower uterine segment, and it is incised transversely, which is described by cord, and this transverse incision is also known as cord incision, whereas other vertical incision confined to the lower uterine segment may also be elected, which was identified by Croning. And a classical incision begins a low vertical incision, extends cephalad into active portion of the uterine corpus, and also a fundal or even posterior incision may be selected for cases with placenta accreta syndromes. So this is a low transverse incision, most common, and the other is low vertical, classical, inverted T or inverted Z. Lower segment. It has less infection as it is retroperitoneal, less incisional site bleeding, easy to repair, inactive part of uterus is involved, so there is lesser rupture and healing is better. The indications of classical cesarean section. If there is difficulty in exposing or safely entering the lower uterine segment, like in case of leiomyoma or cervical cancer, in case of placenta previa, because there is anterior implantation, placenta accreta spectrum, in case of transverse lie, and in case of densely adherent bladder. And before any hysterectomy, we need to, there are some things that need to be done. That is, the surgeon should palpate the fundus, identify the degree of uterine rotation because it will avoid the incision extension into and lateral extension into uterine artery. To prevent this, uh, if there is any kind of dextro rotation, then it should be done. And also, most spoons can be used to pack the protruding bowel away from the intraoperative field. And also, the now we'll identify, as seen in this picture, we'll identify the lower uterine segment by a loose peritoneum fold, and then the deflection of the peritoneum. If after the dissecting, the deflection of the peritoneum at the upper margin of the bladder and overlying the lower uterine grasp into the midline of the forceps and incised transversely. Then upper edge of bladder is applied to front of lower segment and 5 centimeter. You can see this is the bladder and the groove, and it is applied to the front of the lower segment and 5 centimeter below the demarcation line. So we'll identify the loose peritoneum with the forceps, and there will be a fascicular serosa. We'll dissect the layer and then inserting the scissor in between the peritoneum and lower uterine segment. Open scissors are pushed laterally from the midline on each side and cephalad covering the entire lower uterine segment. And this lower edge of the peritoneum is elevated and bladder is gently separated from the underlying lower uterine segment with blunt or sharp dissection within this uterine space. If there is any dense adhesion, it should be also separated, and usually a blunt dissection is separated on the line blunt or sharp direction. The bladder flap creation will move the bladder away from the planned hysterectomy site and prevent bladder restoration during fetal delivery or inferior extension of the bladder. And dense adhesion, sharp dissection is preferred. In case of dense adhesion, sharp dissection is preferred. If there is unclear, then a backfilling can be done for upper border of bladder identification. Now, hysterectomy or uterine incision. The lower uterine segment is identified with digital palpation or at bladder flap incision site. Then we'll use a scalpel and transversely. Then you will use, this is what we have already identified the flap and removed. So now we will use a scalpel and then with transversely incise the lower drug segment by 1 to 2 centimeters midline with repeated shallow stroke to avoid the fetal laceration. And as the myometrium thins, a fingertip or artery forceps is bluntly entered, and once the uterus is opened, the hysterectomy is lengthened by simply spreading the incision using laterally and slightly upward pressure, or cut with keeping two fingers between the membrane and myometrium. So we can do either by keeping the finger inside and cutting, or with two fingers we can extend the incision. Now, if the placenta lies, now there can be some complications like during hysterectomy creation, the placenta lies in the incision site, then must be either detached or incised, and delivery should be done very fastly. Sometimes a low transverse hysterectomy is selected, but there will be inadequate room for delivery. In such cases, one corner can be extended cephalad or contractile portion of the myometrium, causing a Z incision, and also bilaterally a U incision or midline a T incision with higher intraocular loss, mm, and there will be difficulty in prolac as they can be complicated with uterine rupture. That is trial after trial of labor after cesarean section. Now we need to deliver the fetus. In case of cephalic presentation, a hand is slipped in the uterine cavity between the symphysis and fetal head. Then the head is elevated gently with the fingers and palm through the incision, and greater degree of flexion of head will bring the smaller diameter through the incision. And once the head enters the incision, delivery is aided by modest transabdominal fundal pressure. Head is rotated to occiput transverse position. Then it aligns the fetal bisacromial diameter vertically. And after the head delivery, a finger should be passed across the fetal neck to determine whether it is encircled by one or more umbilical cord loops. Then the side of head is grasped with two hands, and gentle downward traction is applied until the anterior shoulder enters the hysterectomy incision. And next, by upward movement, the posterior shoulder is delivered, and with steady outward traction, the whole of the body is delivered. In case of sometimes deeply injured buttocks, a scrub assistant with hand in vagina to push head up from below so that surgeon can deliver is preferred. Pushing anterior shoulder upwards or Trendelenburg position may help in disinfection. If hand cannot be inserted, one braid of forceps can be inserted, which can prevent the extension of uterine incision into lateral vessels or downwards towards vagina. Cord clamping, usually delayed cord clamping for at least 30 to 60 seconds is preferred in case of delivery which do not require any resuscitation, or and it will help in higher hemoglobin level in neonates and iron stores, and facilitate the neonatal fetal to neonatal transition. Delayed clamping is doesn't lower the maternal hemoglobin level in first postoperative day, and after umbilical cord is clamped, the newborn is given to the team member who will conduct care, and care of newborn appropriately trained clinicians should always be available at the time of delivery. Now, delivery of the placenta. The placenta will be absorbed properly with the uterine incision is observed for any vigorous bleeding sites. Spontaneous placental delivery is prompted by contraction and fundal massage. Manual removal of placenta with right hand will increase the risk of endometritis, more maternal blood loss, and longer hospital stay. The uterine cavity is then suctioned and wiped out with a gauze sponge to remove the avos membrane vernix and clots. And oxytocin of 20 units in 1 liter of crystalloids at 10 milliliter per minute is administered IV after delivery of the infant to promote uterine contraction and to prevent PPS. And also injection tranexamic acid 1 gram can be given. Now uterine closure after placental delivery. The uterus is lifted through the incision. The uterus is lifted through the incision and into the draped abdominal wall. That is extrusion, and extrusion is not routinely done these days. So there will be intraperitoneal repair of the uterus would be done. All the bleeding points are easily visualized and repaired, and extension weight on or the patient is obese. Routine not recommended. More pain and does not improve operative outcome of hemorrhage and infections. Before hysterectomy closure, previously clamped large vessels may be ligated separately and incorporated within the running incision closure. IUD insertion. IUD insertion, if planned, is completed prior to hysterectomy closure. One angle of the uterine incision will be collapsed to stabilize and maneuver the incision. Four green armatics are used. The uterine incision is then closed with 1 or 2 layers of continuous zero or number one absorbable suture, usually mono monosyl is used. Continuous locking sutures are applied. Some prefer vicryl. Single layer or double layer is used depending on the clinical circumstances. Single layer closure provides the best anatomical result and strongest scar. Endometriosis does not increase the risk of posterior bleeding or uterine rupture. Single layer is typically faster and not associated with high rate of infection or transfusion. And classical incision should be closed in 3 layers with a baseball suture for final line using fine needle. Now, abdominal closure. Any laparotomy sponges are removed and paracolic gutters and cul-de-sacs are gradually softened or cleaned. Then, prior to abdominal closure, correct sponge management count are verified. Visceral and parietal, visceral and parietal peritoneum need not to be closed to reduce operating time, increase adhesion. Non-closure does not increase hernia, dehiscence, eyelash, or infection rate. So, when a non-closure doesn't increase hernia, dehiscence, eyelash, or infection rate. Post-operative anesthesia improve maternal satisfaction and short and long-term outcomes show no benefit of peritoneal closure. Now, rectus muscle is allowed to fall in place. 1 or 2 figure of 8 sutures with 0 or number 1 catgut suture can be done in case of midnight abdominal incision. And rectus sheath is uh, opposed in a continuous fashion by slowly absorbable suture wound length of 4 to 1. Subcutaneous tissue may not be closed less than 2 centimeter. Suturing can be prevent hematoma and skin can be done with running subcortical or mattress suture. Now Zolcoin and Miscap ladder technique. This is a technique which is done for urgent entry in which the subcutaneous tissue layer is opened sharply to 2 to 3 centimeters in the midline without lateral extension to the fascia. Then a small transverse incision is made in fascia and curved scissors are pushed laterally to each side and beneath the intact subcutaneous fascia to inside the fascia. When the incision is completed, the index finger from each hand is inserted between the rectus abdominis muscles and beneath the fascia. The finger is moved cranially and caudally. One finger is moved cranially and caudally to separate the bellies and further open the fascia. Then the peritoneum is entered sharply and extended cephalocaudally. And in miscavlated technique, the peritoneum is entered bluntly. Also, for emergency delivery, they begin along the line somewhere similar to the pharyngeal. Then the facial incision is bluntly by hooking index finger and also in case of prior we have previous anterior rectus fibrosis and peritoneal area. Now going on with postoperative care, it is best described by ERAS, enhanced recovery after surgery. Vitals are vitals, uterine contraction and vaginal bleeding should be checked every 30 minutes for 2 hours and every 1 hour for 4 hours and every 4 to 6 hours until discharge. Adequate IV fluids are given. We watch for uterine tone, bleeding, wound sockets, administration urine at least 30 ml per hour, and hematocrit should be routinely checked in the morning after surgery and aim to more than 25%. Adequate analgesia with injection pethidine or morphine with antiemetic, or we are using like tramadol, PCM, relax. Early mobilization is encouraged to decrease insulin resistance, muscle atrophy, hypoxia, thromboembolism, and ambulation for high risk patients. Thromboprophylaxis can be given. Folic castration is removed in 6 to 12 hours and in there's immediate post-operative removal unless indicated otherwise. And diet, early intake of ice chips and water in 60 minutes. Regular diet within 4 hours of surgery. Only inspected on third to fourth. Now some special cases like second stage cesarean section, in which the cesarean section is done in full dilated stage. In these case, usually the disinfection of head is required, which is usually done by push or pull technique. In push technique, the operator will insert a hand in vagina and push the head up in flexion using as many fingers as possible. And in pull technique, internal puraling version is done with delivering feet and breath first and trunk followed by after. Similarly, pathogen techniques delivering shoulders, trunk, breath, and lastly the head by reverse breath extraction. Fetal pillow is another automatic device which is inserted in the vagina for flatted after positioning in sudden displaced fetal head. And C snorkel is a passes of air around the head and to overcome the vacuum. Wordless head dragster, single blade device, Tideman tube. These are all the devices according to recent advances 26 and 27. CDMR is the term used as cesarean delivery on maternal request. It recommends that in absence of fetal or maternal indication, plan for vaginal delivery is safe and appropriate and recommended. In following cases, CDMR can be recommended if it is not before 39 weeks. It is should not be motivated by inability of effective pain management. And for women who are desiring several children due to risk of placenta previa, placenta and gravid hysterectomy. Maternal complications usually intravesical laceration, hemorrhage, uterine atony, injury to bladder, injury to uterus, injury to bowel, anesthetic complications like aspiration, inadequate ventilation, local anesthetic toxicity, total spinal or spinal hypotension, and in post-operative postpartum hemorrhage, paralytic ileus, pulmonary atelectasis, infection, pneumonitis, endometritis, wound infection, urinary tract infection, mastitis, hematoma, abdominal distension, nausea, vomiting, venous thromboembolism, or foreign body reaction, sometimes when gauze or any instrument is left inside. Others are fetal complications of prematurity, scalp laceration, in future pregnancy, risks of uterine rupture, antepartum stillbirth, morbidly adherent placenta, in child respiratory morbidity, type 2 diabetes, asthma, and obesity. The risk factors are excessive speed, lack of experience, gestation age below 32 weeks, low gestation vertex, ruptured membrane preoperatively, and maternal death increases 5 times than vaginal delivery. Hemorrhage, first of all, wide lateral dissection of the bladder should be avoided. Any bandage stitcher should be used to cut uterine incision upward concavely and then tearing digitally. Extension of the incision should be prevented during delivery of head. Spontaneous expansion of placenta. Oxytocin used immediately. Clamping the uterine incision with green RPT, rapid closure, and full enclosure of both angles. Vigorous massage, carboprost, billing suture, or box suture, or sometimes uterine artery ligation is required if bleeding is not controlled. Bladder injury, hematuria may occur in first 24 hours and suspicious of bladder injury. Usually, Doyen retractor and rough manipulation of assistant is the cause, and in case of doubt of any integrity and injury, intravenous injection of carmine or methylene blue via the catheter. Bladder repair is done in 2 years by pictil 3 suture and drain continuously with catheter for 5 to 2 days. Infection, the risk is increased by obesity, rupture of membrane, emergency intrapartum surgery, and multiple vaginal examination, bacterial vaginosis. These all will cause increased risk of infection and prophylaxis, skin preparation, skin flames, minimizing tissue trauma, avoiding manual cause of temper fashion, and limiting the people in OT. Thromboprophylaxis, there is usually a risk of venous thromboembolism, pulmonary embolism more than 2 times more than vaginal delivery, more in emergency. RCOG recommends prophylaxis for all, whereas SUG for high risk cases, that is age more than 35 years, high risk thrombophilia, Zepla syndrome, sickle cell disease, any prior events, varicose vein, family history of first degree relative with thromboembolic episodes, obesity, prolonged immobility, preeclampsia, PPS, major illness, and pelvic surgery. Low to moderate like 5 weeks, 5 days, high risk like 6 weeks. Post-operative idea symptoms of distension, colic, and inability to pass. flatus obscure, with persistent nausea, vomiting, prolonged bowel function delay, postpartum uterus can compress the treatment and prevention. For prevention, minimize the bowel manipulation, avoid exercise, fluid or hypovolemia, limit surgery length, calm chewing, enhance early bowel function recovery among studied chewing was initiated immediately or up to 12 hours later. Mm, chewing IV fluids compensate for poor oral intake and losses from emesis. Electrolyte imbalance are corrected, and the nasogastric one day the persistent vomiting or severe distension. Additions, any intraabdominal surgery with each cesarean section rises, lengthen the incision to delivery time and total operative time. Rate of cystotomy and bowel injury are also raised because of adhesive diseases. Prevention, good surgical techniques by minimizing tissue trauma and hemostasis, avoiding infections, suture hydroflotation, NSAIDs, specific adhesion barriers like ceprafilm, interseed, Coretex. In repeat cesarean section, usually the palatal peritoneum should be open as high as possible with great care, and it is too much shallower. So go to dissect this down by blunt dissection. Peripartum cesarean hysterectomy are intractable uterine hemorrhage, placenta acuta, placenta previa, in case of uterine rupture, or gynecological causes like cervical carcinoma. Single layer uterine single layer uterine closure can be done quickly. Uterine extrusion performed. Difficulty is clamping of the broad ligament far more laterally, increasing the risk of ureter. Cesarean myomectomy is safer in case of interval myoma, subserosal or perennial myoma. Myoma is feasible without additional hysterectomy. Multiple myomas, deep intramural, fundal, corneal complications. Mm, and interval myomectomy is preferred due to high vascularity and absolute indication is identified. Perimotum cesarean delivery is operated delivery within 4 to 5 minutes of beginning CPR. Viable and circulation is not restored. Nuisance of zone reduces more if cardiac arrest is with time is rapid. Thank you. So this will be my last slide. Hopefully this was very informative. Good night.